Shot at 4-5. We want to just go just anterior to that. Shot. I'm bumping up against it right now. The trajectory looks good. So I'm going to have to redirect more anterior. Shot. Any questions from the audience so far?
No questions yet, Doc.
All right, so if you're watching the surgery shot today on the 19th of May, can you take a shot, please? Yeah. And go ahead and cone down your field so you're not getting so much back here. You need to close the back up. Do that stuff automatically, Jordan. That's good. That way you avoid radiating my hand too much and everyone else. So if you have questions, you're welcome to ask them. We'll do our best to answer them. As long as they're related to the spine, happy to take your questions. Let's get an AP. Want to see where we are. Our patient is a thin male. He doesn't have a lot of soft tissues for us to pass through, so that always is going to affect the way you do the surgery. That looks good. Back to a lateral. You can see the L5-S1 needle is in perfect position with the tip in the midline. And what I was going to say earlier to you is the hardest disc to fix with transforaminal surgery is L5-S1. There basically is very few to no spine surgeons that do endoscopic surgery in the world. There's probably 50 to 100 endoscopic spine surgeons that I know of worldwide. And of course more are being trained all the time, but not in the United States. Shot. The United States is really starting to lag behind. There's probably only 5 of us in the United States that do endoscopic surgery through tubes like this. Now there's a lot of spine surgeons that tell you they do endoscopic surgery, but they don't really do endoscopic surgery. And they don't really do minimally invasive surgery. This is minimally invasive endoscopic surgery. Shot. So the 5 of us in the United States that do true endoscopic spine surgery, I'll just say 5 to 10, they don't do L5-S1. I'm one of the only ones that do, because L5-S1 is so hard to get to. You're okay through a transforaminal approach. Shot. The endoscopic spine surgeons that do 5-1, L5-S1, they usually do what's called translaminar, where they go through the lamina. All right. Now, why am I hitting the end plate? That's going to be the superior end plate. I'm sorry, the inferior end plate of L4 that I'm hitting. And how is he doing? All right, we're almost done. So I can feel his back is tight. His muscles are tightening up because I think he's just a little bit uncomfortable. But there's not much we can do except to put him to sleep, which I don't want to do right now. I need him awake for a few more minutes. Huh? Oh, perfect. I got it. Just give me a couple of minutes and we'll put you to sleep, okay? So we've lost probably 2 to 3 drops of blood. And we may lose at most another 10 drops. That puts us at about 15 to 20 drops for the surgery. That makes 1 milliliter. Most spine surgeries where you're fixing discs like this, you're looking at losing not 1 milliliter, but 1,000 milliliters for an open back surgery. So 1,000 times more blood loss. Are you comfortable? No.
He's doing okay.
Okay. All right. How bad is that on a scale of 1 to 10?
Dolor?
What number? ¿Qué nombre? 1, 2, 3, 10. 10.
8? 8? 8.
Máximo 8 or máximo más than 8? Terrible Spanish. 9. Ask him if that's where he gets his back pain.
¿Cómo se dice concorde?
No, is that where he typically gets his back pain? So that was L5-S1. It was a 9/10. Ask him if that's where he typically gets back pain. Luis, will you help us?
Es típicamente,
Ahí es donde típicamente siente el dolor,
¿Siempre dolor en la espalda?
en el mismo lugar. Carlos, ahí es donde siente el dolor.
He doesn't have pain.
It's more like symptoms in this case.
I know. But when he does get pain, is that where it is?
Cuando siente el dolor, ahí es que en ese mismo lugar, cuando siente el dolor.
¿Cómo? He feels it the same way.
En the same
Yeah.
way.
Very good. Thank you.
Sorry.
All right. No, it's all right. So he said that is where he typically gets pain, when he gets pain, but most of his symptoms are his leg. I'm not even going to go into the cultural stuff here about back pain, men, certain cultures denying of that they have back pain, etc. But there are definitely cultural influences on how people perceive back pain and talk about back pain and admit they have back pain. You know, in some cultures, it's really looked down upon to complain about back pain. Even in the United States, we have that problem. You know, if you go around telling everyone you have back pain all the time, they just treat you differently and not necessarily in a good way. So, some people learn to deny they have it. They just learn to live with it. But there comes a point when you got to admit it and get it fixed. So that's what we're doing. So we know that the bottom disc causes bad back pain for him, and that it got up to a 9 out of 10. All right, are you better? ¿Tiene duele? All right. This is going to be a tough one to get. How bad is it? What number did it go to?
What's the number? Over 5.
Okay. All right. All right. Well, tell him to pick a number, that the worst it got to. What was the worst it got to?
¿Cuál es el peor? ¿Qué número es más grande?
9?
9.
He said it in English, and I understood it. You Spanish speakers couldn't understand it. Okay, we're going to put him to sleep. So for those of you watching, the test we just did, it's a test. It's called a discogram. Specifically, it's called an evocative discogram. And the purpose of a discogram is to verify that a herniated or degenerated disc is the cause of someone's pain they're having in their neck or back or thoracic. In this case, his lower back. And both the L4-5 and the L5-S1 disc caused back pain. Now, remember, his chief complaint when he came to us was leg pain, leg weakness, and numbness. So it's really a pinched nerve problem from the herniated disc, but he also has back pain from those two discs. So the back pain that he does get is going to be gone after the surgery. Can you ask him to count out loud so we can monitor the progress of his anesthesia?
¿Puede contar el 1 a 100? Ok, cuente, empieza a contar.
You're pulsing? Shot? Bueno. Más, por favor, más. So I'm asking him to count out loud. So when he stops counting, I know he's asleep. En español es okay. 21, 22. Bueno. So he's asleep. He made it to 20, and now he's asleep. So at this point, we're going to be advancing what's called the dilator down into the foramen and into the tear through the herniation. Remember, this degenerative disc disease that he has really starts with a herniated disc. A lot of people get confused. What is a herniated disc? Well, there's a jelly in the center of the disc, kind of like a jelly donut, and then there's a wall around it, kind of like the bread of the donut that holds the jelly in. And if you squeeze on the donut, the jelly doesn't come out a little bit, but if you create a hole and then squeeze, then the jelly comes out. And that's what a herniation is. You got to have a hole first. That hole is called the annular tear. And that's where people's pain comes from. Shot? All right, you can see the tip of the dilator is right at the foramen. We're going to go into that disc right now. There's not a lot of disc left. It's degenerated disc. He's probably lost 80% of the disc. And a lot of people ask me, if you lose 80% or 90% of your disc, if you have degenerative disc disease, can you still have the Deuk laser disc repair to fix it? The answer is yes. Because the same problem that causes the back pain from degenerative disc disease and the problem that causes the leg pain, those are fixable with the laser endoscopically. Shot? All right, we are in that disc. Pull it. It looks like it's getting trapped a little, so you may have to pull hard. There you go. Perfect. Let's see. I'm going to go a little further. So what I'm doing here, show them where the dilator enters the back of the disc. We're going to show you with an arrow on the x-ray, right there. So that's where the dilator is entering the back of the disc. That's where the tear is in the annulus and the herniation was. And the dilator has literally pushed the herniation, part of it, back inside the disc. And we're going to go get it out. So that's why this technique, which was taught to me by Dr. Anthony Young, who's still teaching but is sort of retired from practice. He had set up a endoscopic spine practice over in Phoenix, and I went and trained with him years ago. Now it's been 17 years ago I started training with him over in Phoenix. And he was probably the most influential teacher I had for spine surgery with respect to endoscopic spine surgery. And you know, I trained at one of the top neurosurgery training programs in the world, but at my training program in Gainesville, Florida, they didn't do endoscopic surgery. We did open surgeries like microdiscectomies, laminectomies, fusions, ACDF. And so, thanks, Luis. So when I got done with my neurosurgery training at the University of Florida in Gainesville, I had to learn endoscopic surgery after my training and after my fellowship. I did an additional fellowship in endoscopic surgery from Dr. Anthony Young, and I had to go overseas and learn from Korean, South Korean, and German surgeons who taught me the cervical approach for the cervical spine. Nice, Luis. Way to flex those muscles. So why does a dilator sometimes have trouble coming out? Go ahead and get your fluoro in. I'll show you why. Because look right here. You see this?
We see it.
This is a piece of herniated disc, and it got stuck between the dilator and the tube.
We don't need the x-ray.
Oh, I told him to go back in just to get the verification x-ray. All right, now we can take it out. Anyway, when that little bit of disc herniation gets trapped between the dilator and the tube, it's called a cold welding. It welds the two together, so they move as one. And that's why it's hard sometimes to get that dilator out. But Luis has got the technique, and he's got the muscles. All right. At this point, we're going to... Can you all see this here?
We see
You
it.
see a little wet ray?
Yes, sir.
I'll take this. All right, so this is the needle for the second disc. It's our marker. We're leaving it there. But for the L5-S1, we're going to do the entire surgery through this little 7 millimeter tube. That's why the surgical incision is just 7 millimeters. We're going to do the whole surgery. This is endoscopic surgery, okay? And when you make a big incision and you go in with the tube and everything, that's not endoscopic surgery. But a lot of spine surgeons say what they do, or they cut things and open things, is endoscopic, but it's not. This is true endoscopic lumbar spine surgery. And in the United States, there's probably 5 to 10 surgeons maximum that know how to do this kind of surgery, but they don't do it at L5-S1. They'll do it at L4-5, maybe L3-4. I'm probably the only one in the United States, and maybe one of the few in the world, that does transforaminal L5-S1. And the reason I keep mentioning that to you is because it's important to understand that L5-S1 can be done transforaminal, which is the best way to do it, by the way. A lot of these endoscopic surgeons, they don't do this transforaminal 5-1. They make a cut here, they rip out all the bones and ligaments and drill holes in the bony spine to get down to the disc. That's totally unnecessary as long as you do the technique right. You can go transforaminal. So it's far better for the patient to have transforaminal than to have translaminar or interlaminar, which is what everyone else does, which is destructive to the spine. All right. Anyway, we're going in with the endoscope at this point, and we're going to see what's in there. Let's get the lights down. Yeah, you got to put it in my hand, okay? And you got to put it in the right way, the way that I can use it. All right. There's a piece of herniation right there. Now, there's not going to be a lot of herniation because the disc has already lost 80% of the jelly. And what's left, though, is impinging on the nerve root, meaning pushing on the nerve root and irritating the nerve root, causing the leg symptoms. So my job is going to be to remove the small, little annoying piece of herniation that is causing his leg symptoms. I've been doing this endoscopic surgery now for 16 years. We've done over 1,400 of these surgeries. You got to move a little faster. Don't move like a turtle. Move with a purpose. All right? Lasers on. And I got to tell you, in the 1,400 of these surgeries, I've never had a patient that we didn't get rid of the symptoms where we were operating. Not a single one. So if we're targeting leg pain, weakness, numbness, sometimes the weakness doesn't go away 100% right after surgery, but it takes time to go away. But the pain down the leg goes away right away, and the back pain goes away right away. Now there are people who have other sources of pain besides their disc. And for example, if they have a torn muscle in their buttock called piriformis syndrome, they're still going to have that after the surgery because we're not fixing that. If they have facet pain, which is pain from arthritic facet joints, they're still going to have that facet pain. So the only thing this surgery fixes is disc pain and pinched nerves. And the nerves that are pinched that we're fixing are the ones that are on the side that we're operating at. So you have 5 discs in your lower back, and they could pinch nerves in each disc on the right side or the left side or center. So if you think about it, each disc has 3 spots that we would have potentially to treat to get rid of a pinched nerve. Right, left, center. So 5 discs times 3 spots is 15 different places we'd have to fix, potentially. Most people have 2 or 3 or 4 spots that the nerves are getting pinched. So my job is to figure out which of those 2, 3, or 4 spots need to be fixed, and the other ones don't, because they're not causing pinched nerves. And to do that, I use the physical exam. I examine their back. I examine where their pain is, where their weakness and numbness are on exam. I use the nerve test to see where the pinched nerves are on the nerve test to confirm. my suspicions clinically. And then I use the MRI scan and sometimes x-rays. So by using a combination of MRI, EMG, nerve conduction study, and physical exam, we can usually pinpoint of those 15 places where nerves get pinched in the lower back, we can usually pinpoint which ones are causing that particular patient's pinched nerve. Now look at this right here. That is the herniated disc that was pinching this patient's nerves on the left side at L5-S1. I'm going to get it out with a grabber if I can. So yeah, you don't want to futz around. You want to have that ready to go. And as soon as I hand you the laser, you hand me the grabber. Okay? So that herniation is not coming out in one piece. There's a piece of it right there. That's a pretty good size. See if it stays together. Maybe. I think a little bit of it broke off, but we'll get it. Probably going to need to use a laser on that. So let me go ahead and get the laser. Good. Now that's moving with more purpose. All right, let's show the audience a little animation as to why herniated discs actually cause back pain. By the way, herniated discs are the most common cause of back pain. That's what I've discovered in my career, 26 years of doing treatment of people with chronic back pain. I would say 75% of back pain is due to herniated discs. And then 20% is due to facet joints. And about 5% is due to piriformis syndrome or sacroiliac inflammation or coccydynia, muscles, which is a chronic lumbosacral strain, or fractures, little fractures, tumors, or infections. So the fractures, tumors, and infections are uncommon. But let's go ahead and show the video as to why an annular tear, then herniated disc, will actually cause back pain. It's through inflammation.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
All right, for those of you who haven't seen endoscopic laser, Deuk laser disc repair, that's the laser fiber right there. And the laser is an incredibly precise instrument, surgical instrument. This is a medical laser. It's fully FDA approved. It is built for the purpose of doing tissue ablation. That's exactly what we're using it for. A little bit of bleeding from a little vein there, no big deal. But this is the last part of the herniation. What's that? I just woke up a little, yeah. Grab her. All right. That's why I have the video for you to watch. So you can stay with me. Be prepared. Another herniation there. Tell me when you're ready, doctor. All right, you got to have it the same way every time, okay? It should be the closest loop to me so I can grab it. You have to make it that way. Stand by. You got to hand it to me properly. Okay? That's right, right there. It's your job to put the instrument in my hand in a way that I can use it. You understand?
Yes, sir.
You don't just hold it there and hope that I get it. You have to hand it to me in a way that I can use it. Otherwise, I have to stop the surgery. I have to look at what you're doing. And then I have to go back and look again at the body. And that's not how you're supposed to do assisting.
Yes, sir.
The assistant is supposed to allow the surgeon to keep looking at the anatomy that they're working on and not take their eyes from that and be able to hand them and service their instruments without me stopping what I'm doing.
Yes, sir.
So you have to, what you need to realize is that I always hand the instrument the same way every time. So you have to learn that technique. That make sense?
Yes, sir.
And then you have to make sure it's done properly. Okay, you have it wrong again, right? The closest loop is this wrong one. I can't pull this one. Fix it. Get it right. This is not a job for somebody who doesn't use their brain. You understand?
Yes, sir.
You might think like football or basketball players, they're brainless, but they're not. You know, smart athletes are good athletes. That's because they figure out the right way to do things. Oh, Dr. Berndes, you're killing me. Well, that's... What's the issue?
Just fixing the vents. The oxygen.
All right. Patient's doing good otherwise? Grab the tube. Grab the tube. All right, good. Any questions from our audience?
No current questions, Doc.
All right, so why don't you go ahead and play the animation. Just remember, it's the anesthesiologist, not me. I don't want him to get confused. Of course, we all are. But having tachycardia is not safe. All right. I apologize for the visibility being not so great, but there's a little vein that is giving us a little trouble there. All right, let's show our video then of how the Deuk laser disc repair does its job, how it works. Do you mind doing that there?
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
The L5-S1, and one of my little tricks is to put this grabber in, and what it does is it just helps with the bleeding and the visibility, and particularly the visibility, being able to see. And what I'm seeing looks good. What's left of this disc, and by the way, we're not seeing the whole disc here, we're just seeing a small part of this disc. We're seeing a part that's literally, it may seem like the whole disc to you because of the view, but remember the walls of this tube are about 6 millimeters across. The disc itself is going to be around 6 centimeters. So it's a very big disc. So this is 6 millimeters, and centimeters, there's 10 centimeters per millimeter. I'm sorry, 10 millimeters per centimeter. We're done. So we're looking at really just 10% of the disc right here.
Lights on, please.
Okay.
I mean, not yet, 1 second.
Yeah, scope off is fine.
Okay.
A lot of people think when they see this view that we're looking at the whole disc, but we're not. We're not here to look at the whole disc. We know there's a little part in the back that's where the herniation is, and that's what we're after. So there's no reason to go looking at other parts of the disc. It doesn't help. Come on, come on. Good.
Not too tight, because it's going to need what? There you go. And switch spot.
We're using a little antiseptic here just to clean things out. The antiseptic we use is betadine. Betadine is an iodine-based Antiseptic developed by NASA. Here you go, take this. Thanks. Always think about the needle, like the arc. Where is the needle tip going to be? And don't let your hand go where it's going to be, okay? You're doing great. Coming out. Good. All right, so we're going to apply a little pressure while we wait for the fluoro to come back in. We're going to get back with the fluoro so we can navigate to the next disc. We use the fluoroscope, which is an X-ray machine, to navigate. Surgical navigation is what it's called. And then we also use it for what's called localization. Localization means identifying the proper areas of the spine to operate on. We're localizing, getting to where we need to be, getting to the location of where we need to be. All right. And I'm putting pressure, for those of you who want to do endoscopic spine surgery, I'm actually putting pressure on the muscle. It's the muscle that may ooze a little bit after the procedure. There's nothing else really bleeding. So you want to make sure you're not putting the pressure on the incision. The incision isn't the problem, it's the actual muscle. Shot? All right, looking good. Usually it just takes a few minutes of pressure on the muscle. Shot. Good. And again, you see the function of the guide wire is to guide the actual dilator to the herniation. Now, unlike other types of spine surgery like microdiscectomy, laminectomy, fusions, any other spine surgery except for this, we're not damaging the muscles. We're just spreading them. And muscles have fibers. So it looks like kind of like carpet, shaggy carpet. Imagine sticking your finger in shaggy carpet. You're not actually tearing the fibers. You're just spreading them apart. When you take your finger out of the shaggy carpet hasn't been damaged in any way. The carpet fibers haven't been damaged. So now we're up against the back of that disc. I could feel the herniation itself. Did you hear that? All right, so we're just going to wait a minute. And Dr. Berndes, our anesthesiologist, is trying to keep the patient in a place where he's comfortable but not too sleepy. If patients get too sleepy, they stop breathing, and we don't want that. So he's got a tough job to do. He's probably got the hardest job to do in this operating room, harder than mine as a surgeon for this type of surgery. Huh? Give it a try. So you got to work with your anesthesiologist as a surgeon, always communicating and working in the best interest of the patient and their safety. Safety is so important. The Deuk laser disc repair, we've never had a surgical complication. In 1,400 surgeries, we've had one anesthesia complication. It was not Dr. Berndes, and it wasn't even the anesthesiologist. It was just a patient who basically had, it's very important you tell your surgeon all your medical conditions when you go there. And unfortunately, this particular person didn't tell us about some issues they had, and heavy smoking and drinking. And if you're dishonest about things like drug use and smoking and drinking, you could get into surgery and you're going to have problems, big problems. because your cardiovascular system could fail. And we won't know what's going on because you didn't tell us about, you know, some of the things you do, some of the bad habits you might have. And that's very important to be honest with your surgeon and the anesthesiologist so that they can best prepare to have a safe surgery for you. No? Let me see. Here, try this. It is together. All right, mallet. Shot. Let's try again. That might have freed up the disc. Once again, there's a cold, what we call a cold welding between the tube and the dilator. Yeah? Looks like you got it. You can wiggle it out. Re-grab it. You can re-grab it. You got it. So that worked. Nice job, Luis. Shot. Let's see where we are. That's fine. That's where we need to be. Beautiful. We're in the back of the disc on the left side, remember. So you may look at that x-ray and think we're in the middle, but we're not in the middle. We're on the side. It's going to be right here. It's the opposite of the numbers. We need about 10 more minutes, I think, 15 max. All right, do you have any questions from the audience?
No current questions.
So, what would be an alternative surgery that would work for this patient? There's a procedure called a laminectomy and fusion. And that's what this patient, if they have a proper decompressive laminectomy, foraminotomy, and fusion. Why would a fusion be necessary? Because to get to a foraminal herniation, you have to open up the neuroforamen. And to open up the neuroforamen, you have to remove the facet joint. He's got bad arthritis of the facet joints, and you can't open the foramen and get the pressure off the nerve to treat his leg symptoms from a compressed nerve root unless you open up the foramen completely. And when you do that, you're removing the stability, the facet joint. He's moving a little bit too much. So it's important. And by the way, you've all heard of failed back syndrome, right? Failed back surgery syndrome. What's the number one reason for it? There's something called residual stenosis, meaning that the surgeon did not unpinch the nerve enough. And that's why, because they don't do a foraminotomy. Okay, by doing a foraminotomy, you have to remove the entire facet joint. Once you remove the facet joint, you have instability. So to fix the instability, you have to do a fusion. So the need for fusion is actually predicated on the fact the surgeon is going to do a very extensive decompression of the nerve root in the foramen by unroofing the foramen. And at that point, that segment is going to wobble after surgery. And if it wobbles after surgery, then it's going to create restenosis and pain, and patient will be back for another surgery. What is that, Luis? Huh? See that? Let me see a wiper. Let's see. Keep it there. Keep it there. Huh. Is that a lens issue? Or we have water here?
Can we turn on the lights, please? Thank you.
You have a dry one?
Yes, sir.
Let me see that. We're okay. You may have a lens issue. You may have to send it in.
Scope on, please. Thank you.
Yep. You got a lens issue. Grab her. You're going to learn how to send the scope in, okay?
Okay. That's for you.
I'm talking to you.
Yes, sir.
See, look at the scope.
Yeah, go ahead.
Look at the scope. Look at the camera. Look up there. You see the black line to the right?
Yeah, yeah.
That means the lens is probably out of position.
Okay.
That means it has to be repaired. We got to send it out for repair. Luis will show you how to do that.
We sent already cervical already to the laser fiber.
All right. Oh well.
Yeah.
Let's
Up to you. You want another one? Or-
I'm trying to figure that out. Scopes, lasers on.
Hey, Chris.
I'm not sure yet. I'll tell you in a minute. It almost seems like it's getting worse, doesn't it? Yeah, let's get a new scope. So what I'm working on, and I know it's hard to see because this lens deformity is getting worse, is this is the tear where the herniation came out of, and that's what I'm cleaning up. Let me know when you have the scope. Laser off. Thank you.
You're welcome. Thank you.
See if you can find more scopes, by the way.
Yes, sir. Yes, sir. This one is easier.
The lumbar?
Oh, yeah.
Yeah, I figured as much. All right, so scope on. Good. You can see the difference. Unfortunately, one of our lenses got knocked loose within the shaft of the scope, and that's why it was creating that weird image. The lenses are held in place by glue, special glue, and even special glue fails from time to time. Nice job, nice handoff. Take. Don't let go of that. All right, let's go ahead and show a video that compares the Deuk laser disc repair, what we're doing now, with an alternative type of surgery called a decompression and fusion, just so you can see the difference. You see the Deuk laser disc repair is less invasive, and there's no fusion obviously with this surgery, so you're not losing any movement. The recovery is much faster with the Deuk laser disc repair.
Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A patient with chronic back or neck pain originating from a symptomatic disc injury could undergo either traditional spinal fusion or less invasive Deuk laser disc repair. This MRI represents a typical case with L4-5 and L5-S1 symptomatic discs. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, two patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a half an inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spine, the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. To accommodate the fusion hardware, a large bone grabber is used to perform a laminectomy by removing bone from the spine. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large pedicle screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before released to go home. The fusion screws are inserted into the bone, as shown in the X-ray. After all screws are in place, rods are used to connect the screws together to prevent movement of the secured vertebrae. Cross-links are added to bridge the rods together for additional stability. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. The Deuk laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. Prior to closing the wound, a temporary drain is installed to allow excess fluid to drain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Deuk laser disc repair's 1/2 inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Deuk laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Deuk laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Deuk laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Deuk laser disc repair, there is no damage to the muscles. The Deuk laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Deuk laser disc repair. Spinal fusions have a high risk for infection. The Deuk laser disc repair has a very low risk for infection. In the 7 years the Deuk laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself. Whereas the recovery from Deuk laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement. Whereas there is no fusion with the Deuk laser disc repair. Normal movements of the joints in the spine is preserved. Spinal fusion results in loss of mobility. There is no mobility loss with the Deuk laser disc repair. In fact, most Deuk laser disc repair patients experience improved mobility after the surgery. The Deuk laser disc repair is FDA approved. All the instruments and equipment used are FDA approved. This proprietary surgery itself has been peer-reviewed and published and is performed exclusively at the Deuk Spine Institute. With the highest published success rate of 95%, the Deuk laser disc repair is proven to be the most successful and least damaging spinal surgery in the world for the treatment of symptomatic damaged discs causing back pain, neck pain, sciatica, and radiculopathy due to herniated, degenerated, or bulging discs.
All right, we're just wrapping up the L4-5 disc on the left side for this patient. Well, I just need the anesthesiologist to tell me if that's enough. That's all. Is that enough? It's looking pretty good there. Let's see the this should be it. Maybe something lateral there. Got to get the junk out of the middle. Okay, it's not a grabbing, pinching, it's a pushing the material into the mouth and then pulling it out. Good, that's better. You see, the thing is, this disc herniation is sticky. And if you push that Raytech into the mouth, it'll grab it and pull it out for you. Make sense?
Yes, sir.
So you don't want to just grab around the mouth, you want to push the material into the mouth.
Push it and out. That's a big one.
Here. Just about done here.
Thank you.
Any questions from our audience?
No current questions.
All right, we're done. So if you have questions, feel free to type them up. That's what we're here to do, is answer those questions for you as well. Otherwise, we're done with a L4-5 and L5-S1 degenerative disc disease with neuroforaminal stenosis, pinched nerves, and radiculopathy. Patient also had back pain, but he was so basically inactive that he wasn't getting the back pain very much, but he constantly had the leg symptoms. Here, put your hand up for a second. Oscar, put your hand like this. I want to show you something. This is clogged, by the way. Here. All right. Grab that. All right, now hold your hand up. No, like this, okay? Like this. That's the grabber, right, with tissue in here. If you just go like this, you're not going to get it. You have to go like this. So it's more of a, like this. All right, can you guys see the incision here?
Yes, we can.
All right, I'm going to show it to you in just a moment. You can see just how small this incision is and how small the hole is that we created. And this hole, this tunnel, is now collapsed because we were using a tubular retractor to hold the muscle apart. Now we've taken it out. The muscle fibers have come back together. Here you go. See that? Tiny Band-Aid incision. This is the Band-Aid spine surgery you've heard about for years. This is the procedure. You got it? We're going to put a little Band-Aid on there. Good work, everybody. Overall, I was very happy with the way the surgery went. We got into the herniations with the needle in the beginning very quickly without any issues. And I think the patient's done well from an anesthesia standpoint. He's been very comfortable throughout the case. He's been stable. He's going to make a great recovery. He's going to go home in about an hour from now. These surgeries are outpatient. No complications. EBL, I'm going to call 3 mil. And this was a left. Uh-huh. All right, Deuk laser disc repair. Go ahead and type up your questions for me. I'll head over and I'll answer them for you face to face. Next, we got another Deuk laser disc repair lumbar, correct? What do we have, 4 lumbars today? Dr. Ardik Majan here at Deuk Spine Institute. It's Groundhog Day, I believe, right? February 2nd, so 2/2/2022. And I'm here with one of my patients who traveled from, where did you come from?
Tennessee.
Tennessee. And why would you travel from Tennessee to Florida to Deuk Spine Institute?
I have been miserable for months, and I found you and did a consult with you and knew this is where I needed to come for good treatment and relief.
And what kind of problem were you having that brought you to Deuk Spine Institute?
Severe lower back pain, which turned into sciatica, and it was down my left leg constantly. I slept about 2-3 hours a night at most, and I could not sit for more than 5 minutes, and I had to be standing up.
And did you try some other treatments in Tennessee or elsewhere?
I did. When this whole thing started and it was a bad flare, I thought I'll be able to work through this. Chiropractic, physical therapy, 2 spinal injections, massage therapy.
And how did you know those treatments did not work for you?
I had no relief at all. My sleeping continued to get worse, and my pain was never better.
And do you have relief now?
Absolutely. I would say I have 95% relief.
Awesome.
And it's amazing. After surgery yesterday, I put on a back brace. I walked out of here. I sat down yesterday for probably over an hour and had lunch. Last night, in bed, I had 0 pain. It's a miracle.
Well, we're very happy that you're doing so well. And your surgery was a great one because we fixed 2 discs. You had herniated disc at L4-5, L5-S1. And you can see in this footage right here that we grabbed the herniation out. And it was one of the herniations was really big. And it was really gratifying to get it off because it was resting on your sciatic nerve. Once we took it out, I think your sciatic nerve probably felt a sigh of relief.
Yes, absolutely.
Yeah, and the surgery went very well. The laser debridement of the annulus went well. And I feel like your pain's going to be gone. It's not going to come back.
I would agree.
All right, very good. Well, is there anything else you want to tell your viewers?
Folks, if you're suffering and you're not getting relief from those non-invasive therapies, then come see Dr. Deuk and have him look at your MRI and give a good diagnosis. And if you need to have surgery, you come down here. He will take good care of you, and so will his team.
I really appreciate that. Thank you so much.
Thank you.
I'm Dr. Deuk. It's January 26, 2022, and I'm here with one of my patients who you underwent the Deuk laser disc repair on your lower back for some herniated discs about a week ago.
Yes,
How are you feeling today?
unbelievable. For almost 3 years, I had lower back pain, and it just, it just nags at you, wears you out. And then I came here, and you were the first one. I went to 2 other surgeons, and neither one of them picked up what was wrong with me, even though I had the MRI. And you came in, and you told me exactly what was going on, and you performed the laser surgery, and I'm like a different person.
Yeah.
A week later.
Yeah, you were a different person the next day, right? The day after, you had no pain, remember?
No, absolutely.
Yeah, so that pain's gone for the rest of your life. How does that make you feel?
New life.
Good. And, a long time ago, remember when people did something great, you say, what are you going to do now? They say, I'm going to Disneyland. You already went, I can see.
No, my wife's a big Disneyland fan.
Good for you. All right, so sounds like we helped you with your back pain, and it sounds like you're very satisfied.
Oh yeah, I'm recommending a friend of mine in Connecticut to come here. You have to come here. If you go anywhere else, I really think you're going to be wasting your time. So this guy just looks at you, and he can tell what needs to be done. He's a fantastic talent, and I'm very grateful that I came here.
Well, we're grateful you did too, because it's going to change your life for the better. Congratulations.
Thank you, Doc.
You're welcome. Good morning, I'm Dr. Deuk, and I'm here with one of my patients, and you traveled to Deuk Spine Institute here in Florida from where?
New York, Poughkeepsie, New York.
Awesome. And why did you come from New York to Deuk Spine here in Florida?
Because I heard that this was the best place for me to go.
What kind of problems were you having that you needed to come here?
I had lower back problems and numbness in my leg, which was my left leg. This was the best place for me to come.
Okay, so you had back pain, sciatica down your left leg, pain shooting down the left leg.
Yes.
And that was just yesterday, right? When you
yes,
had
that's
that.
correct. Yeah.
And what, do you still have your back pain today?
No more back pain.
It's gone.
Gone.
And is that because we have you doped up on powerful painkillers?
Nope. None
No, it
whatsoever.
isn't. Did anybody in New York offer you spine surgery to fix your back?
Yep. Yes, they did.
Yeah.
And they wanted to fuse it.
Yeah. And you've had surgery before. You had a microdiscectomy, and that helped you for a little while,
Yes.
but the symptoms came back.
Came back.
Yeah. All right, well, they're not going to come back this time. So what do we do to make your pain go away?
You fixed my back. You did orthoscopic.
That's right, arthroscopic spine surgery called the Deuk laser disc repair. So leg pain's gone, back pain's gone.
Everything is gone.
You happy?
You did. I'm very happy.
You're smiling.
Yeah. I tell you.
Congratulations.
Thank you so much.
We did it all through a 7mm incision, just that big. And you can actually watch that video right here, an animation, to see what it looks like to do the Deuk laser disc repair.
A Band-Aid sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own.
So now that your surgery's done, what are you going to do?
I'm going to go home and enjoy my life.
Good for you.
Enjoy my life.
Congratulations.
I'm very happy.
Anything you want to tell your viewers?
Other than this is the place to come, it's worth the travel.
Disc herniations are a common cause of chronic neck pain. The inflamed annular tear causes neck pain. Inflammation of the nerve roots causes arm pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. It can take up to 12 months. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.deukspine.com.
Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, two patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a half an inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spine, the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before released to go home. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. The Deuk laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Average surgery time of a traditional 2-level fusion is 2.5 hours. with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Deuk laser disc repair's half-inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Deuk laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Deuk laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Deuk laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Deuk laser disc repair, there is no damage to the muscles. The Deuk laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Deuk laser disc repair. Spinal fusions have a high risk for infection. The Deuk laser disc repair has a very low risk for infection. In the 7 years the Deuk laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself. Whereas the recovery from Deuk laser...
Hello, I'm Dr. Deuk Majan, and we have just completed our first surgery for today, March 19, 2022, at the Deuk Spine Institute, where we treat herniated disc, bulging disc, degenerated disc, ruptured disc, extruded disc, slipped disc, protruding disc, basically anything to do with a disc that causes symptoms. Discs, when they get damaged, can cause, if it's in the lower back pain, as well as irritate the nerves that go past the disc where the herniation is. So nerves will come out of this hole right here called the neuroforamen, right past the herniation, and they go down your leg. And that will cause leg pain. We call it sciatica. It can also cause neurogenic claudication, which is where your legs start feeling heavy and tired with standing and walking. Gets better when you sit down. And they also cause tingling, numbness, and weakness down in the leg. You can start dragging your foot due to a pinched nerve. So nerve conditions associated with a herniated or bulging disc or degenerated disc include, thank you Karen, include numbness, tingling, weakness, and pain down the leg. Also, herniated discs cause back pain. So this patient had little back pain, but that's really because he was completely inactive. He had just shut down the quality of his life. He wasn't doing anything. He was extremely inactive. His muscles in his back have atrophied as a result of the lack of activity. So people with pain, chronic pain that comes from joints, like spine or hip or knee, what they do is they end up avoiding activities that exacerbate their pain, and that includes pretty much every activity. And it may start with things like golfing or jogging or weights, but eventually it becomes just walking will be affected with pain. And so people then stop walking and they basically become a couch potato. Their quality of life goes away in order to avoid setting off the back pain. So what we believe in Deuk Spine Institute is curing the pain so that they can go back to do whatever they want. Now there are two ways to cure pain from a degenerated or herniated disc. One is to do a fusion where we clean the disc out, put a cage in there, and we fuse the bones together. And so if you want to know what a fusion looks like, this is what a fusion looks like. You've got screws and rods, and we would clean out the disc, remove it completely, scrape the ends of the bones, top and bottom, pack in bone graft, some cadaver bone, put a cage in there, and do a fusion. So there's no more movement at that segment. You still have movement above, and you have movement below the fusion, but you have zero movement at the fusion itself. And that will take away the back pain that comes from a herniated disc. But why go through a massive surgery like a fusion? Very destructive, bloody scar tissue, long recovery of months, if not years, pain and suffering and lots of narcotic painkillers. You could avoid all that by having endoscopic spine surgery. That's what we do at Deuk Spine. That's the surgery we just completed today. So this patient had endoscopic Deuk laser disc repair, where I debride the annular tear and eliminate back pain. We also decompress the nerves in the foramen that were being pinched by herniations and osteophytes. All right, let's take our first question from the audience.
From Beth from Facebook, she's asked.
Hi, Beth from Facebook.
She's asked, how bad was this patient's degenerative disc disease?
So Beth is asking, how bad was this patient's degenerative disc disease? Well, let's talk for a moment. What is degenerative disc disease? Okay, degenerative disc disease is really a disease that affects, of course, the disc. The disc is really a kind of a cartilaginous cushion between bones in your spine. We call these parts of the bones the vertebral body. That's the yellow thing here, the yellow thing here. Now, you really want to try to have something between the bones when the bones move. And that's what the disc job is to do. So if you get an injury to the disc and you get inflammation in that injury, it will cause the whole disc to just get destroyed. It's like putting a piece of meat in acid. Over time, that acid will dissolve that meat away. It'll literally dissolve it. And that's what happens in degenerative disc disease. You first get a herniated disc, you get inflammation, and the inflammation spreads for years throughout the disc, like acid destroying the disc, causing the disc to collapse down, and it causes changes in the bones, the surfaces of the bones above and below. We call those sclerotic changes and modic changes, spelled M-O-D-I-C. And a lot of those things, the modic changes, the pitting, the irregularity of the surface, the sclerosis or reinforcement of the cortical bone, and the collapsing of the disc height, all that degenerative stuff really doesn't cause any symptoms, it turns out. But a lot of surgeons and people believe that it does, but it doesn't. And for years, I used to treat degenerative disc disease by cleaning the disc out, putting a cage in, fusing it with screws and rods. But then I started doing the laser surgery because people didn't want the fusion. And guess what? The results were better with laser surgery. And they had zero pain, great movement, no back pain, no leg pain, perfectly normal. And yet there was bone on bone, there was all the sclerotic stuff, there all the irregularity and bone cysts, modic type 2, type 3 changes, doesn't matter. Normal, no back pain, no leg pain, no weakness, no numbness, no tingling, totally normal. And I realized this whole fusion thing and cages, it's all overkill. It's totally unnecessary because it doesn't add any benefit to the patient's quality of life, and it doesn't improve the disease in any way. So that was an epiphany for me as a spine surgeon. And now all we pretty much do is Deuk laser disc repairs on everybody. And they have degenerative disc disease, but it's asymptomatic when we're done with surgery.
Next question is from Reiko Pilot on YouTube.
Reiko Pilot, thank you for asking on YouTube.
Yeah, and he asks, this fixes the disc, but if the problem is the curve, and I think he meant by cervical, can that be fixed to prevent future issues after you fix the pain?
All right. First of all, great question. I get this quite a bit. Curves. Curves are very important in the spine. And again, here's the problem. The curve in the cervical spine is lordotic, and the curve in the thoracic spine is kyphotic, and the curve in the lumbar spine is lordotic, backwards. I got to be honest, I trained at a top neurosurgery program in spine. Everything was about curves and stenosis and stability. And what I found, though, is that by doing the Deuk laser disc repair, even though we don't repair the curve, we still eliminate pain completely and restore normal function. So this whole business about the curve is, honest to God, over dramatized, overemphasized. And I will tell you this, curves are something patients can relate to. It's easy to convince a patient they need treatment, whether it's chiropractic treatment, shots, surgery. It's easy to convince them when you show them an abnormal curve, because then they go, oh, I can see it. Oh, I see what you're talking about. But honestly, it's totally unnecessary to fix a curve 98% of the time. There are going to be some exceptions, right? There are going to be people who have what are called chin-on-chest deformity. You've seen them. They're walking around, their head is down like this. They cannot look up. Those people are completely debilitated, but because, number one, they're visually, they don't have their eyes on the horizon, that's a problem. And then balance-wise, it's hard to have good balance and do things when your head's down like this. So those people do need a curve fixing surgery, all right? And that's going to be a laminectomy infusion through the back with correction of deformity. But when you've got neck pain and a herniated disc and you've got an abnormal curve, you don't need your curve fixed. You don't need chiropractic. It's not going to fix your problem. You need those discs or facet joints that are causing your pain treated and fixed so there's no more pain from them. Your curve will improve on its own because the muscle spasms will reduce and your curve will usually go back to a more lordotic curve. I hope that explains it to you. I have no reason to lie to you about any of this stuff. I fix curves. I've done it for years. I put in screws and rods. Go to the Deuk Spine Institute YouTube channel. Look at playlists and look up cervical laminectomy and fusion. You can see that I've done many, many fusion surgeries with instrumentation. I'm not afraid to do any spine surgery, and I've done hundreds and thousands of different kinds of surgeries on the spine, including fusions, artificial disc, laminectomy, curve correction. And that's what I used to preach to everybody for years, how important curve correction was. But the truth is, now that I'm doing laser surgery, I'm curing everyone's pain without correcting the curves. So unfortunately, I have to recant what I had told so many people years ago about curve correction, because it's just simply not true. Any other questions?
That is it.
Have a nice day. We'll be back in about 30 minutes with surgery number 2. It's going to be another Deuk laser disc repair. And this patient has a herniated disc at L2-3, both sides at L3-4, and then on the right side at L4-5. So we're going to do a right 2-3, right 4-5, and bilateral 3-4. See you soon.